The Nelson study is is the second largest screening study. Uses low dose volume CT to screen people for lung cancer, and the control group was no screening at all. And they randomised around 15,000 patients to either the volume CT or the control group, and we had some preliminary data published back in October 18, and since then we've been waiting for the final publication of the mortality data. The Nelson trial has been absolutely fantastic. It's given us loads of information about nodule management and risk of malignancy, which is now guiding us in the form of the British Thoracic Society guidelines. We're using routine volumetry now in the UK in many centres, and hope that continues to roll out. But the mortality figures have been weighted quite eagerly by the policymakers. And while we've been waiting for the mortality, in fact, we've moved things on very considerably in the UK in any case, even though Nelson was not finally published. We haven't fully evaluated the Nelson paper yet. It requires a really detailed read, but what I am aware of is the final mortality results are as we expected. The male mortality reduction was around about 24%, and the female mortality reduction was considerably more than that as well. So it's very, very encouraging. And remember, this mortality reduction is something that will continue if you continue to screen the population. So the number of lives saved is related to how many people you detect with lung cancer and how long you screen them for. So great result, and really good to see that finally published. In terms of where we are with the UK screening, everyone will be aware of the announcement the end of beginning of last year, 2019, of a very ambitious pilot programme of targeted CT screening within a lung health check programme in 10 cancer alliances in England. And that decision was made before even the publication of or preliminary publication of the Nelson results at the World Lung Cancer Conference in Toronto in 2018. So we'd already gone some way to indicating that this was a very highly effective programme. And I think since that time, many people who were initially sceptical about the cost effectiveness of this intervention have been convinced that this is very, very effective. And some people are estimating that this might save more lives than both the breast and the bowel cancer screening programme put together, provided it's done really well and there's significant participation amongst the people at risk. In terms of a national programme, the issue with the England pilots is that it's only England. It ignores the other 3 countries in the UK. Whereas if a screening programme is approved by the UK National Screening Committee, it's adopted by all of the 4 countries. And one of the big breakthrough has been after publication of a report by Professor Sir Mike Richards, which recommended that targeted screening programmes, that is to say programmes that are targeted according to the risk of the disease that they're trying to detect, should be given the same emphasis and the same expertise applied to them as the population screening programmes, and suggested that a body like the UK National Screening Committee should take this on. And that has since been endorsed by Matt Hancock in Parliament, and he has asked the 4 Chief Medical Officers to liaise to try and deliver this through Public Health England. So at the moment we're in a situation where it looks like we're going to be using the CT screening programme for lung cancer as the first exemplar of a targeted programme. And it's a very exciting process now to see how this will actually work, how we will develop the pilots that are have already started or about to start into a rollout of a full national screening programme, which will be equal in its priority to the breast, bowel and cervical cancer screening programmes. We're working on that, and many people and experts will be involved in the various discussions over the next few years.